Endoscopic retrograde cholangiopancreatography is a standard endoscopic procedure for diagnosis and treatment of pancreatic or biliary diseases. Despite major advances in instrumentation, selective bile duct cannulation remains the greatest hurdle, and difficult or failed selective bile duct cannulations are sometimes associated with post-ERCP pancreatitis that accounts for substantial morbidity and occasional mortality. The wire-guided cannulation technique, which is an alternative to the standard contrast injection method, facilitates selective bile duct cannulation by using a radioplaque guide wire passed through a tip of a catheter under fluoroscopic guidance. Although the results of prospective studies are conflicting, a recent meta-analysis revealed that using wire-guided cannulation increases the success rate of selective bile duct cannulation and reduces the risk of PEP. While treatment using wire-guided cannulation is usually successful after a few attempts, a rescue technique such as pre-cut sphincterectomy or the double-guidewire cannulation methods is sometimes applied after several unintentional insertions of the guide wire into the pancreatic duct. The double-guidewire method employs a second guide wire along the first. The latter, that is placed in the pancreatic duct, fixes the papilla. A previous study of patients with difficult selective bile duct cannulation found that the double online guide wire technique was disadvantageous for achieving either selective bile duct cannulation or preventing PEP. In that study, because randomization was performed between cannulation attempts, pancreatic duct cannulation was successful only in 75% of the procedures, and thus the selective bile duct cannulation success rate was less than 50% in the double guide wire group. To evaluate the success rate of selective bile duct cannulation with the double guide wire method, randomization should be done only when there is already a guide wire in the main pancreatic duct. Furthermore, early conversion to the double guide wire method may eliminate the risk of PEP due to papillary trauma caused by the repeated cannulation attempts that were reported for early pre-cut sphincterectomies. To test our hypothesis that early application of the double guide wire technique, particularly at the first unintentional insertion of a guide wire into the pancreatic duct, may facilitate selective bile duct cannulation and reduce PEP, we conducted a multicenter randomized controlled trial, the early double guide wire cannulation or education study, of early recourse to the double guide wire method compared with repeated use of the single guide wire method. Background and study aims. There are no guidelines for the timing of conversion from a single guide wire to a double guide wire technique to facilitate selective bile duct cannulation and reduce post-endoscopic retrograde cholangiopancreatography pancreatitis when using wire-guided cannulation. We investigated whether early conversion to the double guide wire method, at first unintentional insertion of a guide wire into the pancreatic duct, facilitated selective bile duct cannulation and reduced PEP compared with repeated single guide wire attempts. A multi-center prospective randomized controlled trial included 274 patients with a naive papilla undergoing endoscopic retrograde cholangiography using wire-guided cannulation in whom there was an unintentional insertion of the guide wire into the pancreatic duct. With the guide wire still in the duct, patients were randomly assigned to undergo the double guide wire technique or repeated single wire cannulation. Main outcomes were success rates for selective bile duct cannulation and PEP frequency. Results. Success rates for selective bile duct cannulation within 10 attempts in 10 minutes were 75% and 70% respectively for the early double guide wire and repeated single guide wire cannulation groups. Relative rate 1.07, 95% confidence interval, 95% CI, 0.93 through 1.24, p equals 0.42. Corresponding final selective bile duct cannulation rates were 98 and 97%. Relative rate 1.01, 95% CI, 0.97 through 1.05, p equals 1. PEP rates were 20% and 17%, respectively, for the EDG and RSG cannulation groups. Relative risk 1.17, 95% CI, 0.71 through 1.94, p equals 0.53. Double guidewire cannulation was more effective in patients with malignant biliary structure. Relative rate 1.36, 95% CI, 1.05 through 1.77, p equals 0.02. Conclusions. During therapeutic ERC using wire-guided cannulation, converting to a double guidewire technique neither facilitated selective bile duct cannulation nor decreased PEP incidence compared with repeated use of a single wire technique.